Hello class. Let's begin our last system, and we're going to talk specifically about the renal and the urinary system. Now mind you, we have been kind of throwing in bits and pieces of the renal system and how it correlates and pertains to the many other systems that we have talked about. But now we're going to just focus entirely on the renal and urinary system. And hopefully a lot of these things will start to make sense when we talk about how the system works and how we look at both macro and micro structures of the kidney to kind of get a sense of how it all works together by many, many processes. So it might be a good time to get out your anatomy and physiology books and just begin to review some of the structures and parts and pieces of the renal urinary system to kind of remember the important manifestations or features of that particular structure, and how when each piece and each structure is healthy and works to its potential, then we have somebody who has a very healthy and a very normal renal urinary system, which is very important. Because it's more than just the process of making urine. This particular system does that and a whole lot more. These are some of the functions and the role of what our kidneys do for us. They maintain body fluid composition, which is a big one because, let's face it, that's probably one of the most important assessments we make on our patient. What do they take in? And what do they put out? And those kidneys are quite responsible for filtering waste products. They help regulate blood pressure. Think about it. How do they do that? It goes back to the process of the compensatory mechanisms such as the renin-angiotensin-aldosterone system. Renin comes from a particular part of the kidneys, and that's what begins that process to help bring blood pressure up. And of course the all-important acid-base balance, production of erythropoietin for red blood cell synthesis. Let's go back to our hematology, how we talked about the growth factor with erythropoietin necessary to make red blood cells, and of course the conversion of vitamin D to an active form. When we talked about that in regards to the parathyroid glands and how important the process of the kidneys were in that conversion of vitamin D to an active form. It's just a little review of the anatomy and physiology. We know where the kidneys are. They're located behind the peritoneum. And each kidney is about 4 to 5 inches long, about 2 to 3 inches wide, and 1 inch thick. And the left kidney is slightly longer and narrower than the right kidney. And sometimes in certain pathologies, we may see kidneys larger than usual. That could be visualized on some of the diagnostics that we're going to talk about later. Could be due to the fact that a person has renal obstruction or polycystic disease. And if it's smaller than usual, that may also be very abnormal to indicate that they have some kind of chronic kidney disease. And I think it's important to really point out that the renal system is just more than the kidneys. Yes, it's a big part of that system because that's where urine is made, that's where a lot of processes occur. But you have to think about the entire urinary tract. We have, of course, the kidneys. We have the bladder. We have the ureters. And we have the urethra. And when we suspect that a person does have a kidney problem, that's where we begin a very thorough assessment of the patient. Because then we can see all the potential factors that were involved that put them at risk for a kidney problem or the risk that actually caused them to have an actual problem. So, that's really important to, determine, what the cause is. And sometimes just the first indication that there may be kidney insufficiency is just by assessing a urinalysis and noting that there's glucose or there's microalbuminuria. So those are some of the clues or the red flags that kind of alert us as nurses that your patient may have some kind of renal insufficiency. When we look at the kidney, the outer surface has that renal capsule, and this covers most except that hilum. And beneath the renal capsule are 2 layers of functional kidney tissues, and these terms are probably quite familiar to you because we talked about the cortex and the medulla with the adrenal glands, but now the kidneys actually have structures of a cortex and a medulla. And the renal cortex is that outer tissue layer, and that's what's covered by the renal capsule. And the medulla lies below the cortex, so you're getting more inward in the kidney below the cortex in the shape of fans called pyramids. And each kidney has about 12 to 18 of these pyramids per each kidney. And then at the end of this pyramid is this papilla, and then further inward you have your calyces or your calyx, which actually collects the urine at each of the papilla. Now you're in that renal pelvis, and those within that renal pelvis are those calyces that join together to form this. And I think the important thing to remember when we're talking about kidneys is it has such a rich supply of blood. I mean, look at this. It receives about 20 to 25% of the total cardiac output. Receives blood from the renal artery, and we kind of give the renal tissue a fancy name, and we call that parenchyma. And you have to remember, too, that anytime we have a person or our patients who have some kind of disorder of the renal system, it really, really and truly affects the whole body. And again, we will see a patient develop alterations in fluid and electrolyte balances, and really starts to affect cardiovascular function and even nutritional status. And really, to have a healthy renal system function will depend on the health of other body systems. Your cardiovascular, your circulatory, endocrine, and even your nervous system. Remember, we do divide some of the structures within the renal system as either macro or micro. And within the macro structures, we have, of course, 2 kidneys, 2 ureters, a urinary bladder, and a urethra. And as I said before, each structure is essential to the total function of the renal system. And another thing to remember, too, is that if you look at the kidney, it really has those 3 distinct regions that we just talked about: the cortex, the medulla, and the renal pelvis. Okay, just to kind of, get a sense of that. And we could go into a lot more depth in describing the renal medulla and the renal cortex. I'll let you guys read about that just so you get a better sense of what each of those distinct regions of the kidney have within them, and really what is significant about each part of that kidney, and how it functions. Okay. This is just a picture, the anatomic location of some of the organs of the renal urinary system. As you look at the top part, you can see how that right kidney does sit a little bit lower. And then look on top, you see the infamous adrenal glands. And then you can see that renal artery, which really provides that blood supply to the kidney. And this is where I said, when we talked about the cardiac system, where some of these renal arteries can actually have stenosis, where many times that is treated with a stent, just like we do in the coronary arteries. You see how the abdominal aorta lies very close, especially to the left kidney, and ascending downward is the ureters. And it's very significant. You really can't tell real well in this picture, but with the ureters, they do have definite changes in the dimension and the thickness of those ureters. And then you can see where the sigmoid colon cut is, and then coming down into the from the ureters into the urinary bladder. And this happens to be a picture of a female, and you can see how where the uterus sits in relation to the bladder and to the ureters. Okay, just a little visual, so you can kind of get a sense of where all those organs are. So later on, when we talk about some of the problems and the pathologies that occur in these structures, you'll know exactly what area we're discussing, so that you can kind of see that visual in your head. Okay. Now we're going to talk about the microstructure, and this is very, very important in regards to how urine is formed. Nephrons, they are actually the functional unit of the kidney within the micro structures of the kidney, and this is exactly where urine is formed. And to me, this is just absolutely amazing, is that about 1 million nephrons per kidney. So you can imagine when a person becomes chronic renal failure, or even really has significant renal insufficiency, you can see how many nephrons have been destroyed by whatever reason to put a patient in that situation. Because look, we have 1 million of them per kidney, okay? And to me, I find that just absolutely incredible that unfortunately disease or some kind of pathology has taken over those nephrons and caused them to be non-functioning, causing your patient to have very, very significant renal insufficiency. But you can even kind of get a little bit more specific in regards to your nephrons. We have two types. We have the cortical and the juxtamedullary, okay? And each one of those really does serve a distinct purpose, okay? Your cortical nephrons are short, and all of those are located in your renal cortex, okay? And they account for about 80% of your nephrons. Your juxtamedullary are about 20% of all your nephrons. They're longer, and they kind of start into the medulla. And what makes them a little bit different than your cortical nephrons are is that they actually concentrate urine. So for instance, if you're outside on a hot day, you're not drinking a lot, your intake has really been quite decreased. When you urinate, your urine will be quite concentrated, less fluid lost, and that will prevent you from losing less fluid, but you're still excreting waste for even the little bit amount of urine that you may excrete. So that's kind of the difference between those two types of nephrons, okay? But each nephron separately makes urine from blood, okay? And we're going to talk in a few minutes about urine formation. And blood supply to those nephrons through the afferent arterial, then to the glomerulus, then to the afferent arterial. So just a little quick A&P just to kind of get you now thinking about the specific structures and how things occur within the body, especially with our patients when we're talking about their health. And these nephrons are extremely small, but they do have very distinctive parts that each serve a very, very important process or job, okay? You have your Bowman's capsule, And your Bowman's capsule is what kind of is around your glomerulus. And actually, within the nephron, the tubes begin with the Bowman's capsule. And your Bowman's capsule will start to narrow into the proximal convoluted tubule, and we call that the PCT. And what convoluted means, it's kind of just twisted and turned. And the PCT twists and turns, finally straightening into the descending limb of the loop of Henle. And there are two segments of the ascending limb of the loop of Henle. There's a thin segment and a thick segment. And then it goes to the distal convoluted tubing that forms from the thick segment of the ascending limb of the loop of Henle. Kind of looks like that. And your distal convoluted tubing ends in one of the many collecting ducts located in the kidney tissues. The urine in the collecting ducts passes through the papilla and empties into the renal pelvis, as I explained before. This picture is kind of a very crude picture, but it does give you an idea of how important these tubules are, okay? And this is all very small because this is very much a part of the nephron. This is actually the anatomy of the nephron, the functional unit of the kidney. And this is actually a juxtamedullary nephron, okay? It begins in the, with Bowman's capsule, which is right here. And then it comes in through here first, and this is where your glomerulus is. And we all know what that is. That is just like a capillary membrane, and this is how the blood flow goes into that, and Bowman's capsule is kind of surrounds that. And then it follows the route through the proximal convoluted tubule, as you see up here, and then down here to the ascending loop of Henle, the descending loop of Henle, and then it kind of turns around, and then it goes to the ascending loop of Henle. And this is very familiar to you because this is exactly where the medication furosemide or Lasix works. It's a loop diuretic, and this is exactly where that process occurs, where less water is absorbed and more water is excreted, giving a person very much that diuretic effect. Another thing I wanted to point out too is you can see in this crude picture that you can see how within these tubules how they are very thick here, and then they kind of narrow out a little bit more as they ascend upward, okay, and continue through the distal convoluted tubule into the collecting ducts, into those pyramids, and then urine flowing through the renal pelvis, out through the ureters, into the bladder, and then through the urethra as one begins to urinate. Just a couple things about this drawing is when we talk about ascending and descending loop of Henle, what's important to know is on the descending side, this is where a lot of water is reabsorbed and happens passively, okay? And remember that this is, I'm trying to make it so it's understandable that this is where most of that water is absorbed in the process of making urine, because if this was not reabsorbed, you would be excreting a large amount of urine and eventually become dehydrated and lose all that volume, and it would be not compatible with life. On the ascending side, this is where a lot of the electrolytes like sodium, chloride, and potassium are reabsorbed, and it's very impermeable to water. So it's very important that these tubules remain healthy and are not facing adversity with disease or structural damage, because these are very significant areas where through the making of urine certain things are absorbed, such as water, and then certain things like electrolytes are absorbed. So when these are not functioning correctly, you're going to have some imbalances of water and electrolyte balances. So I just wanted to kind of stress that. And to me, again, these are very microstructures, but they sure do a significant amount of work that keep fluids, water balance, and electrolytes all very stable, so that a person remains very healthy and has no issues with fluid and electrolyte problems. All right, we're going to talk now about kidney function. And two of those functions have to do with regulatory versus hormonal function. And some of this, again, is things that we have already discussed in other systems. So some of it will be new and others will be just a refresher. But you can see, again, how many of the systems that we've talked about have very much overlapped with the renal system and some of the hormones that are specific to the renal system. This regulatory function really does play a role in controlling fluid, electrolytes, and acid-base balance. Really is basically the way in which the nephron actually forms urine. Remember, as I said before, each kidney contains about 1 million nephrons, which process the blood to make urine. So it's very necessary that in order to make urine, someone must have a decent blood pressure to be able to form urine. So does this all start to make sense when we've stressed in this whole course how important adequate blood pressure is to make urine, okay? And remember, each nephron contains a tuft of capillaries called the glomerulus, which is completely surrounded by that glomerulus capsule that we call Bowman's capsule, okay? And remember, the complex structures of the kidney process about 180 liters, and that's equal to about 47 gallons of blood derived from fluid each day. So you can see what an incredible job these nephrons have. And only 1% of that amount of fluid is excreted as urine. The rest is returned to circulation. And this is what I said before, because if more of that was lost, what you would have is somebody very depleted of fluids, and you would eventually have a person that would die, because that would be not compatible with life. And urine formation is accompanied entirely by the nephron through 3 processes, okay? Glomerular filtration, tubular reabsorption, and tubular secretion. And through those 3 processes, that's what helps to maintain fluid, electrolytes, and acid-base balance, okay? So let's talk specifically about each one of these processes, okay? You have to think, too, of the kidneys in regards to the many systems that are involved, okay? Of course, let me see. Let me kind of refresh your memory about all the systems that the kidney, or all the processes that the kidneys use. Filtration, diffusion, active transport, and osmosis, okay? So You know, and it makes sense because there's so many structures involved, and each one does their part in maintaining homeostasis through one of those processes that I just mentioned. And the first one is filtration. And this blood that's coming in through the renal artery goes through the glomerulus first, and this is why it is the first process in the making of urine, okay? So blood will pass through the afferent arteriole into the glomerulus, then across the glomerulus membrane into Bowman's capsule to form what we call that glomerular filtrate, okay? And I just want to kind of get into a little bit more so it makes more sense to you. But glomerular filtration is more of a passive process in which you need hydrostatic pressure that'll force fluids and solutes through that membrane, okay? And passive means it can't do that on its own. It has to have some help or assistance, okay? It's like when we do passive range of motion on somebody. You as the nurse or the physical therapist does passive range of motions on a person because you initiate the activity or the movement of that person's extremity. They're not doing it on their own. This is the same principle behind passive filtration, or the passive process that occurs within glomerular filtration, okay? So where does this assistance or help with this process occur? And when we talk about hydrostatic pressure, what that is the pressure exerted by fluids such as blood and tissue fluids against the walls of the capillaries. And that makes sense because this blood is passing through the glomerulus, which is kind of a tuft or a network of capillary membrane. So the source of that pressure is the pumping action of the heart. So that's why the heart has to be effective, has to effectively pump blood to the kidneys through the nephron, through this structure called the glomerulus. And so you have the source of the pumping of the heart, and there are some differences in pressures between the arterial and the venous end. And your blood pressure tends to force those materials out of the capillaries and actually into the surrounding tissue fluid. And if you have a healthy glomerulus, proteins and water and some of the dissolved substances will stay in there, okay, and will not be processed out. Remember, hydrostatic pressure is the push and osmotic pressure is the pull. So the glomerular hydrostatic pressure pushes water and solutes across the membrane, and this pressure is opposed by the osmotic pressure in the glomerulus, primarily the colloid osmotic pressure of plasma proteins. Remember how we talked about plasma proteins in hematology, how those keep the pressure and the volume in the vascular space? Well, this is exactly what we're talking about now. So you have a push and a pull going on here, and you have capillary hydrostatic pressure exerted by fluids with a glomerular capsule, and the difference between the forces determines the net filtration pressure, which is directly proportional to your patient's or to a person's glomerular filtration rate. Because you've got the pushing of the heart against the colloid pressure, or the colloid osmotic pressure. So you got one force against the other. The normal GFR in both kidneys is about 120 to 125 milliliters per minute in an adult. And this is why when a person has blood pressure problems, when blood pressure drops below 70 millimeters of mercury, then GFR stops, okay? That's why if somebody becomes very, very hypotensive, they don't make urine. And this is why. So when you see a patient's output really begin to start to drop, the first thing you want to look at is this due to the fact that your patient now has a low blood pressure causing the process of GFR to stop. Okay, and that may be the case. Might be a hypovolemic shock, and sometimes the problem is a cardiac problem, because remember, the force of that blood through that glomerulus to start the process of making urine is all happening because of that hydrostatic pressure from the beating and pumping of the heart action. So see, guys, how this is all interrelated? We've been already talking about this, but now hopefully it makes a lot more sense to you, okay? So large particles such as blood cells, albumin, and other proteins are too large to filter through, so those won't normally be present in the urine. So GFR is controlled by blood pressure and blood flow. So when blood pressure drops below 70 millimeters of mercury, so does GFR, okay? So that's the first process, glomerular filtration. I hope everyone understands that. Please reread this in your book or listen to me again. I want it to be clear that you really understand about the importance of blood pressure to begin this process of making urine. Without that, without adequate blood pressure, you're never going to have this process occur, okay? So the second one, or the second process within the regulatory function of the kidneys is tubular reabsorption, okay? This is the reabsorption of most of the filtrate that keeps urine output to about 1 to 3 liters per day. This is the process that prevents dehydration. So this is why, as I said before, that these tubules in the nephrons need to be healthy, not scarred, because this reabsorption process of the filtrate needs to happen, because this is what reabsorbs most of that fluid so that you don't lose a lot of fluid through dehydration. Does that make sense? So you have return particles such as solutes and water back into the blood, and this is responsible for more than 99% of all filtered water back into the body, okay? And this is the second process of tubular reabsorption. And remember, we talked about renal threshold for your patients that are diabetics. It's around 220. So if somebody has a blood glucose of 400, then they're definitely beyond the renal threshold, and they're going to show glycosuria in the urine, meaning there's going to be a significant amount of glucose present in the urine because the kidneys can only reabsorb so much. That blood sugar is so high that it goes beyond renal threshold. Some of the abnormalities that we do not want to see in the urine is albumin, glucose, erythrocytes, ketones, and leukocytes. And we're going to get into that very specifically about what is normal for a routine urinalysis, because all our patients who are admitted in acute care setting are asked to give a urine specimen, so a urinalysis can be done on every patient that's admitted. And we'll talk about what is normal and what is not normal. And then the last one is, and remember too, when we talk about tubular reabsorption, just to kind of throw in this, this is that process that begins as the filtrate enters the proximal tubules, okay? And the tubules constantly regulate and adjust the rate and degree of water and ion reabsorption in response to hormonal signals. We'll talk about those hormones that really do control what water is absorbed and what is actually excreted. And then the last one is tubular secretion. This is a process which is important for disposing of substances not already in the filtrate, such as medications. This is when, medications will be excreted through the kidneys. This is when that will happen, okay? So it's reabsorption in reverse, eliminates undesirable substances that have been reabsorbed by passive processes, and actually begins to rid the body of excess potassium ions. It is also an important and vital force in the regulation of blood pH. This is when all that happens. So remember I said before when we talked about electrolytes, the amount of potassium you take in is the amount of potassium that you put out, okay? And this all happens in those distal convoluted tubules, okay? So that's the regulatory part of the kidneys. Basically, it's just how urine is made. 3 processes: glomerular filtration, tubular reabsorption, and lastly, tubular secretion. So please read that over again so that makes a lot of sense to you, because really the important piece of information that I want you to get from that is you definitely need a substantial blood pressure to have that blood brought into the glomerulus to begin the process of actually making urine, okay? So that's the regulatory function, okay? And when we talk about, hormones, we're going to, think about the hormones that we've already talked about in the endocrine system: ADH, aldosterone. All those work on certain tubules in the nephron to control blood pressure and to alter, what is reabsorbed as far as solutes and what is reabsorbed and excreted as far as water. Okay, so that is the regulatory system. All right. So the next one is the hormonal function. Okay, and this kind of works in conjunction with the regulatory function, as I said, because much of what is absorbed and excreted is really dependent on the kind of signals that they get from a particular type of hormone, okay? Obviously, we've talked a lot about renin, assist in blood pressure control. And renin assists in blood pressure control. It's detected through the receptors of the juxtaglomerular complex. And obviously it raises blood pressure as a result of angiotensin and aldosterone. Really very responsible hormone, very important hormone in the renin-angiotensin aldosterone system. Okay, your prostaglandins are prostaglandins such as E2. They help regulate glomerular filtration, kidney vascular resistance, and renin production. These prostaglandins can act on the distal tubules and collecting ducts to increase sodium and water excretion. So they really do affect blood pressure as well, okay? And we've talked somewhat about prostaglandins in the past, okay? And then the next one is your bradykinin. These are released by the kidney in response to the presence of angiotensin II, prostaglandins, and even ADH. It's a small hormone that will actually dilate the afferent arteriole and increase capillary membrane permeability to some of the solutes, okay? Helps to maintain kidney blood flow and reabsorption, even with blood vessel constriction, okay? So very much acts in the presence of some of these other hormones, such as ADH and even prostaglandins, okay? So those are your bradykinin and then erythropoietin produced and released in response to decreased O2 tension in the renal blood supply when it senses, decreased red blood cell production. Erythropoietin must be present for those, for the production and for the process of erythropoiesis. And then, of course, vitamin D, activated through a series of steps. Exposure to sunlight, processed in the liver to an active form, then needed to absorb calcium in the intestinal tract to regulate calcium balance. And if we go back to our, as I said before, our parathyroid glands, this will all be as clear as a clean plate of glass. So see how all these have kind of overlapped from other systems that we have already discussed. I'm not going to get into a lot of anatomy details. You can read these. I just kind of put these on the PowerPoint slides to kind of remind you about the particular structure and how specialized it is, and the certain important features that each of these structures have to keep the renal system healthy. Each kidney has a single ureter, a hollow tube that connects the renal pelvis with the bladder. And you can see that, again, this is a tube-like structure that definitely changes the diameter of the ureter because it kind of narrows in 3 different parts. Consists of 3 layers, and it does have a contraction of the smooth muscle occurs to actually move urine from the renal pelvis of the kidney down to the bladder. Okay, and this is important to know because think about our patients later on that we're going to talk about that have kidney stones or renal calculi. Most of the time these will move and be passed through the ureters, but if they're large enough they can cause some very, very serious obstruction and actually do damage to these certain layers of the ureter within the renal system. So just wanted to kind of remind you about that. Okay. Then the next one is the bladder, which is a muscular sac, men in front of the rectum, women in front of the vagina, lies directly behind the pubic bone. And that is composed of the body and bladder neck, and that has also 3 linings. Inner lining of epithelial cells, the middle layer of smooth muscle. This is important, detrusor muscle, because we're going to talk about when that has a dysfunction to it. This is why some women later on in life, after birthing children, will have problems with their distressor muscle and develop the problem of incontinence. And then the last layer is that outer layer, or outer lining of the bladder. And this is what exactly the bladder does. It's a temporary urine storage site, provides continence and enables voiding. Secretions of the lining resist bacteria. And continence, that's the ability to voluntarily control bladder emptying, which is controlled by a lot of things, our awareness, and also by the central nervous system. This is just a gross anatomy of the urinary bladder, okay? And urethra. This is a male patient because right now you can see we have a prostate there. So, and this can later on give problems to the urinary system if this prostate does enlarge and causes obstruction of urinary flow. And then, of course, lastly, the urethra, which is a narrow tube lined with mucous membranes and epithelial cells, and the purpose is to eliminate urine from the bladder. Urethral meatus is an opening as the end point of the urethra. Men, it's about 6 to 8 inches the tip of the penis. Women, it's much shorter, only about 1 and 1.5 inches. Lies slightly below the clitoris and directly in front of the vagina and rectum. You can see that this anatomy is significantly important because this is why women are so prone to urinary tract infections. And with all systems, we'll just talk somewhat about the renal changes with aging. Kidneys lose cortical tissue and get smaller by 80 years of age. And the reason for this is it's caused by decreased blood flow to the kidneys. Okay. The medulla is not affected by aging, just the cortical tissues are. The glomerular and tubular linings start to thicken, so that may affect the way things are absorbed and secreted. Both the number of glomeruli and their surface areas start to decrease with aging, and the tubular links start to decrease also. And that affects the ability to filter blood and excrete waste products. GFR starts to decrease, especially after 45, and by 65 decreases half the rate of a young adult. And remember, some of our patients with other comorbidities such as diabetes, hypertension, and CHF, this decline in GFR progresses much faster. Patients are much more risk for overload, and drug reactions, kidney damage from drug, and contrast dyes. So when we start seeing renal insufficiency with these people, it's important that we kind of help to preserve the function of what's left by using very potent medications or nephrotoxic drugs or even contrast dyes very sparingly, only when necessary, to prevent any further deterioration of kidney function. As we age, there's a decreased ability to concentrate urine, so people have more urgency, nocturnal polyuria, decreased hormones such as renin, aldosterone, and activation of vitamin D all occur in addition. You also have a decreased bladder capacity and weakened urinary sphincter muscles. So that's why you might see problems with a tendency to retain urine, a decreased ability to clear medications, prone to hypernatremia and fluid volume deficit, decreased osmotic stimulation of thirst. Men, one of the big problems they have as they get older is the development of BPH, which is benign prostate hypertrophy. And with women after menopause, with the decrease in progesterone and estrogen, there's vaginal and urethral tissue atrophy. And we see many problems with urinary incontinence with men with prostate problems and women, obviously, with many other factors, many vaginal bursts, excess weight, and just the loss of the protective functions of hormones such as progesterone and estrogen. And sometimes these all things occur too. Incontinence, loss of self-esteem, decreased involvement in social activities. And we see a varying degree of incontinence from mild to very severe. And older women, as I said before, risk for incontinence due to hormonal changes. And men have BPH problems, increased infection due to inadequate fluid intake, immobility conditions that lead to urinary stasis. And along with incontinence leads to skin breakdown. So that's why it's important that people seek ways in which they can control that better, especially the elderly as their skin turgor begins to change. We don't want more skin breakdown because of incontinence and that urine stasis on the skin. As with every system, assessment is very, very important. Just demographics in themselves, regards to age, gender, race, and ethnicity. Sometimes we see what happens in patients 50 years or over. They suddenly develop an onset of hypertension, which, if not treated, could later on cause future kidney disease. And of course, men, as they age, as I said before, prostate disease. Remember, men rarely have UTIs unless they have some abnormalities. urethral reflux or prostate problems, and many of them can get problems with some of the STDs out there, your sexual transmitted infections. Remember, because of the anatomy of a woman, women have shorter urethras and more commonly develop UTIs such as cystitis, which we'll talk about soon. We look at previous kidney disease. Have they had any tumors, infections, stones, or even any surgeries on the renal system? Do they have diabetes or hypertension? Because we know with uncontrolled diabetes, it can damage kidney vessels along with hypertension. Have they been exposed to chemicals, hydrocarbons, gasoline, oils, mercury, and even lead? Drug use, heroin, cocaine, inhalants, even have you ever been told about protein or albumin in the urine? A woman's pregnancy history can lead to problems with, incontinence. Did they have proteinuria in their urine while they're pregnant? Did they have blood pressure issues, gestational diabetes, or history of UTIs while being pregnant? Environmental toxins, any recent travels that would increase the risk for infections, disease risk, trauma, and definitely sexual contacts. Really looking at dietary history, patients who are at risk for calculi, who ingest too many proteins, especially your males who tend to really take in a lot of protein to build muscle, bodybuilders, things like that. If you've had kidney stones in the past, usually we like to strain all urine to send those specimens of those stones down to see what they're actually made of. And a lot of that can be related to diet. Medication history, antibiotics, over-the-counter medications such as certain vitamins, some of your herbs, NSAIDs, things like that. Genetic disposition, it's Bright's disease, nephritis, nephrosis, and really current health problems. What's the appearance of your urine look like? Do you go enough during the day? Normally, people urinate about 1,500 to 2,000 milliliters a day. Is it painful? Does it burn? Does your urine have a foul smell? All that stuff is important to ask the person. What does the person's physical assessment look like? What's their general appearance, their color? Do they have rashes, bruising, or other discolorations, which could signify kidney disease? Sometimes a lot of these kidney problems are due to the fact that people lack the funds or the insurance to access health care, lack of transportation, reduced income, cannot afford to have their prescriptions filled, and do not have the time and the money to go for follow-up appointments. And again, the physical assessment, assessing kidneys, ureters, and bladder through abdominal assessment, observe patient for symmetry, discoloration, and bruising, and possibly listening for that bruising on the renal artery. Renal palpation should really be done by a person of experience. Maybe as some of you become nurse practitioners, that will be your area of expertise. Nutrition is a big part in renal, because especially with protein, making sure patients take in a proper food and fluid intake, what type of fluids they drink, water, a lot of dehydrating fluids. Really, we should take in about 3 liters of fluid a day, unless there's some kind of fluid restriction. That's really important to kind of get a little history of what some of the beverages that these patients, ingest. And sometimes it's necessary to really assess the urethra. We don't usually do that on a routine assessment. Obviously, if a patient needs a Foley catheter, we're going to definitely be able to assess the urethra. Our urethra would be assessed probably for a very serious, maybe an STI. A patient was assaulted physically or sexually, looking for any changes in the tissue, lesions, rashes, irritation. It's a very invasive assessment, so you really want to try to put your patient as much ease as possible, because it's just like when women have babies, it's there, and you want to be as respectful and kind and make the patient feel as least comfortable as possible, because a lot of times these assessments and exposures may have some psychosocial or psychological effect on these patients, particularly if they've had some very serious issues with rape or physical assault or physical abuse in the past. So be very sensitive to that. And it's also probably a good idea if you knew about that before you approached a patient, so you could be very sensitive to the situation. Okay, so that's just a brief summary of some of the assessment findings for your patients that might have some renal or urinary issues. Read through those so that you're a little bit more familiar with what specifics you would ask your patient as far as kind of to learn what may be the cause of some of their issues or renal problems at this point. And I just want to kind of bring your attention to certain terms that we'll probably use throughout the renal system. Urgency, that's a need to void immediately. So when you ask your patient if they have urgency, make sure they understand what they're being asked. Micturition is just a fancy term for the act of voiding. Nocturia is urinating at night. Frequency is the feeling or the need to void often or many times. Hesitancy is the difficulty in initiating the flow of urine. Anuria is urine that's about 50 to 100 milliliters in a 24-hour time. Oliguria is about 100 to 400 milliliters in a 24-hour period of time. The term azotemia is increased BUN and serum creatinine. Renal impairment, no outward signs of renal failure. Dysuria is pain when urinating. Polyuria is a lot of urination. We've talked about that with diabetes. Usually over 2,000 mLs in a 24-hour period. So those are some very common terms. Also, another one, I'm sorry, I forgot to tell you, is uremic failure. That's when you have nitrogenous waste products characterized or manifested by anorexia, nausea and vomiting, muscle cramps, itching, pruritus, fatigue, and lethargy. Okay, so that's uremic failure.